Started. This is the first Geriatrics, Gerontology, and Palliative Care Medicine grand rounds. Sorry for any confusion or the lateness. We'll go as far as possible, and feel free to leave when you have to, and you'll get the credit for when you leave, and I'm going to give you the most credit as possible, like I said before. So our first speaker is going to be Samy Habib, and he is the Associate Professor of Cellular and Structural Biology at VA, and he is a structural biologist at the UTHSCSA Washout Institute. So without further delay, Dr. Habib.
Thank you. I just need to know what time frame you have. So most of my talk will be clinical. I know you do mainly clinical, and the time we do some biochemical analysis in the lab to confirm some, at least what we see in a clinical way, but I just need to know, my talk may be about 45 minutes to 1 hour. We can exceed, we can short it, whatever you like, we can squeeze. So just let me know. Right now, almost like 12:55. So 45 minutes would be okay, or 1 hour would be okay for you?
We have the patients at 1.
You have something at 1. All of you? Oh, okay.
So I'm not sure.
No, I can actually give you at least what we have found in last. Let me give you just a little bit introduction. My main background in cancer, liver and kidney, do mainly mechanism, how liver cancer develop, how kidney cancer develop. I came to be new in diabetes field since I joined the UTHSCSA Center in 2003. I found people work in diabetes, but my background in cancer, so I asked myself, is there any link between diabetes and cancer? So at the time I said, okay, we can actually start to do some biochemical analysis using a cell from kidney, and we can do animal model, but in addition to that, can we have link between diabetes and cancer as a clinical study? And this was actually main concern for me to find at least something related to renal cancer. So all of you know that a lot of complication develop during diabetes, but to the certain point, when you get to the chronic diabetes, can you get cancer? This is the main actually problem. So as you can see from the slide here, there's a lot of complication from hyperglycemia and hyperinsulinemia. But in addition to that, by chronic exposure, 15, 20 years, sometimes some people, they can actually develop cancer. So we are in Texas, we have very bad actually endemic disease as a diabetes. As you can see the color, once you go darker, you can see higher incidence of diabetes. 10.6, this is a darker one, this is 10.6 of 10,000 people they have diabetes. And when we look at cancer in this state, also we have higher level of cancer in Texas, 16.8 to 19 people of out of 100,000 people they have also cancer, kidney cancer and other type of cancer. So when we talk about age little bit, I just need to tell you about the age. People with under 20 years old, they have higher little bit incidence. As you can see, the percentage here, 0.26 of all people that under 20 years old, okay? So 1 in every 400. But I will go directly to age 65. The 65 years old people, they have 26.9. If you multiply the first one, the first row, which is the 20, under 20. If you multiply this number by 100, you will get people with a higher level of diabetes, about 65 years old. So you expect people under 20 years old, higher level of them, they have actually a diabetes by reaching the age of 65 and up. But look at age 20 years or older. Also, we have higher incidence of diabetes in the United States, 25.6 million, which about to 11.3 of people, they have actually diabetes. When you look at man and woman, there is no big difference between a man and a woman regarding diabetes. 13 million, 12.6 million, both of them almost the same. I'm talking about 20 years old and above. And when you look at type 1 and type 2 diabetes, do we have higher level of type 1 or type 2 diabetes? So under 10 years old, you can see majority of people here, they have diabetes. Here I'm talking about ethnicity or race. So all of them here, and you can see the darker color as a dark green, that's the type 2 diabetes. This is non-Hispanic white, non-Hispanic black, and Hispanic and American, I believe American Indian. This is the last one. But look at type 2 diabetes. Type 2 diabetes in age of 10 to 19 years old. You can see higher level here in old. I'm talking about old. So compare old to old here, you can see higher level of type 2 diabetes once you go age 10 to 19 years old. The point here, do we have some strong association between diabetes and cancer? So I will go very quickly to incidence of mortality of diabetes, incidence mortality of cancer, and we can see how is mortality in people with diabetes and cancer. And I will share with you very quickly some published data from different places in the world that the link between diabetes, type 1 diabetes and cancer, and type 2 diabetes and cancer. So as you can see, in the United States here we are around 26 million people that have diabetes, 8.3. In Texas we are large in everything, so we have almost 10% of all other states, which is still very high. When we talk about cancer, in all world about 11.4, in the United States about 1.5, still very high, 14%. And in Texas we have around 4%. Here I'm talking about all general cancer, not specific one. So when we talk about mortality in cancer alone or diabetes alone, in cancer alone about 23.3, in diabetes alone around 3%. But very interesting study published just 3 years ago in New England Journal of Medicine. Those people, they actually screen 820,000 people for diabetes. They have 96 prospective study from 25 countries. They found actually 123,205 deaths as a cause of diabetes. So they listed the cancer as the second cause of death in diabetic patients, which is still, that's very high compared, because we know vascular is number 1, but cancer number 2 is still, this is actually very interesting study. So the question always we ask, is type 1 diabetes associated with certain cancer compared to type 2 diabetes? So there is a nice study here from Sweden. They look at 29,000 patients from Sweden. They hospitalized from 1965 to 1999, almost like 35 years. And they look at the association between other cancers. They found actually several cancers associated with type 1 diabetes. When other studies look at type 2 diabetes, they found actually different type of cancer. See here you can see stomach, cervix, and other. Here you can see pancreatic, kidney, and breast. So there is also site of specificity between type of diabetes and the organ that develop cancer. So people also search for, in general, type 1 and type 2 here. I'm talking about in general diabetes and type of cancer. They have association between diabetes and liver cancer in one study here. In other study between breast cancer, colorectal cancer, ovarian cancer, no association here, which is actually good for a woman. But keep in mind, man is better here. Prostate cancer is associated with decreased risk of cancer. So something still people at least negotiate about this type of study, But if prostate cancer can develop, diabetes can develop prostate cancer still under investigation. I'm jumped directly to pancreas, which is majority of people with diabetes, 80% of patients, they have actually pancreas cancer. And nice study also published almost like 10 years ago. The search between 1980 to 1994, almost 15 years, 800,000 people. They look at all those people doing dialysis, and they found there is actually a big association between kidney cancer, urinary tract in patients under dialysis from 4 continental, United States, Europe, Australia, and New Zealand. And another study, big study here, they actually collected 1 million, over 1 million people, men, and almost 500,000 women, and they found increased serum glucose level is associated with incidence of several cancer, as you see here. So I will talk a little bit later about cell type of renal cell carcinoma. So in general, we have at least 5 types of renal cell. The first one is the highest one, which is called clear cell carcinoma. The second one is papillary type 1, and papillary type 2, and chromophobe, and oncocytoma. Majority of clear cell carcinoma associated with certain gene mutation called VHL or Van Hebel-Lindau, but other one distributed around maybe 25%. So as you can see here, the kidney as a structure, majority of the cortex area, this area, that actually developed this type of renal cancer. So this is a slide of diabetes. As you can see, majority of tubular cell, distal tubular or proximal tubular cell, located directly in the cortex area, as you can see, which is the tumor development. And which we do actually mainly in the lab when we isolate the cell, we isolate it from cortex area that have a lot of tubular cell. See how nice is the normal kidney section under microscope, the H&E staining, how bad the kidney section from diabetes. You can see a lot of hypertrophy, glomerulosclerosis, and thickness of the membrane in distal tubular cell and also proximal tubular cell. But once you go to RCC or renal cell carcinoma, you can see this is a clear cell carcinoma. There is no nucleus inside the cell. Most of the cell doesn't have any cytoplasm. But once you have diabetes and cancer, you can see how bad actually this type of section under microscope. So today I will share with you some data we have done in 2 years, and even we collected new data in last 2 years to see how is people with diabetes can be under risk of renal cell carcinoma. So this data published actually 2 years ago when we collected 473 candidates. They have renal cell carcinoma. We found around 56% they are male and 43% male. Female, sorry. And when we searched those candidates, we found 56% of those actually, they have diabetes history, like 20.8%. And when we look at the female, we found 31% of them, they have history with diabetes. When we divided the total number of 120 by 430, it came actually very high, 25%. So 25% of all patients, they have history with diabetes, which is very, very high. So this is actually screening all candidates from 1994 until 2009. This is a 15 years work. So I just need to share with you unpublished data we just collected. So right now, the percentage reached actually 33.3%. So from 25, as you can see, 25%, we are right now, in the last 2 years, we just searched all candidates between 2010 until 2012. So we can see that still the male and female almost close to each other, but I'm talking about the percentage, reach around 33.3%, which is very high. So when we look at the distribution of all renal cancer with or without diabetes according to ethnicity and gender from the old study, we found actually the majority of them, they are Hispanic. 75% they are Hispanic. About 20% they are white, and 5.8% they are other. But looking at Hispanic group, at the time when we collected the data, for me it was actually not surprising, since the Hispanic, they have some genetically affecting by diabetes, so I was expecting that Hispanic would be at higher risk compared to white. But look at the new data we just have right now. So when we look at the new data, we have total of 78 cases of renal cell carcinoma. Okay, 26% of them, 26 of the 78, which is 33%, they are mainly white. There is no Hispanic at all, and 6 are other. Maybe you ask me, maybe this number is very low, but I'm talking about 3 years screening from 2010 until 2012. So the point here, which sometimes I ask myself, what's going on? I'm still expecting the Hispanic group will be at higher risk for kidney cancer compared to other, but this is actually surprising that 73% of those candidates, they are white, and 23 they are other. So we did actually distribute all this data, so we try to extract more data from the all file. The file is, we have it in my desk. This is too many files, because we look at all this file, we need to find out what's the last level of high glucose in the patient before nephrectomy. This is very important for us. We don't use actually level of glucose in every time. We use the high glucose level before the surgery to mark it down and have some idea. But here, when we look at the age, you can see how the 50 to 59 years old people, they have higher incidence, which is among all, this is the highest incidence of diabetes in kidney cancer. When we go to renal cell carcinoma with diabetes, we found also mainly those age between 50 to 59, they have higher incidence of renal cell carcinoma. Of course, we collected, as I told you, the hemoglobin 1C level before the nephrectomy. We collected the urine sample to see the creatinine level, to see the liver function, and also we have the last record of glucose level in this patient. We didn't see the difference between male and female regarding glucose level. Maybe the creatinine level here in male high, but still is not a very strong, significant compared to female. But again, the hemoglobin 1C in both male and female high, according to ADA, American Diabetes Association, they mentioned that hemoglobin 1C in normal patients should be between 5.5 to 6 milligram per deciliter. But here you can see, this is the way when we look at the data, we look at the data without hemoglobin 1C and glucose level, we cannot actually make judgment. Those people, they have actually history with diabetes. So this data at least confirm for us that we have at least people with higher level hyperglycemia and higher level of hemoglobin 1C. So this is a new study of the 3 years. Still, we see that the same age, 50 to 59, that they have higher risk of kidney cancer. So 61.5% of diabetic patients, they have kidney cancer. And again, hemoglobin 1C here came almost to normal. Creatinine, there is no difference between male and female, but when we talk about total, again, there is no difference. When we look at the average of glucose level between our patients here, the average between 142 to 252 in a male, 158 to 280 in female. So here is still the link. There is some link regarding that those people, they have hyperglycemia. The point, sometimes we cannot actually have access to the record to see if those people under medication or other stuff. So that at least one factor we can include in the future. So when we look at the data sheet, how those people they actually get the tissue and start to do some histology stuff. So we look at, remember when I told you about cell type in cancer, this is the majority of cell type, it's called clear cell carcinoma. We found that 92% of those people, they have clear cell carcinoma. So this is very aggressive type of cell, which is sometimes will be hard for treatment, which at least when you talk about early tumor compared to mid tumor or advanced tumor, that also affecting the treatment. When we look at the nuclear grade, we found a majority of them, 56%, they are in grade nuclear grade number 2. When we look at the tumor size, which is very important also for us, we found majority of them, they are with a tumor size between 1 to 5 centimeters. And again, we link that again to very important point, which is hemoglobin 1C. So we found that hemoglobin 1C is around 8 in Hispanic, around 6 in white, and around 6 also in other. But again, glucose level is still high than normal. So this is a new study we have done, like I told you in the last year. Again, we found that clear cell carcinoma, almost 100% of the cancers, they are actually a clear cell type. We found also again 75% they have nuclear grade, majority of them. And again, the tumor size 1 to 5 centimeter, again the majority of them they have 1 to 5 centimeter. When we done the study for the 15 years work for screening those patients, we look at to find also how is the glucose level matching with the tumor size. Can we see glucose level higher in tumor size 10 centimeter and above? What we saw, actually we saw reverse. Look at this number and look at the tumor size. From 1 to 5 centimeter, almost 150. 5 to 10 centimeter is 146. But when you go to up to 10 centimeter, you have glucose level 85. That's a question mark here. Why bigger tumor, they have higher, lower level of glucose and lower level of the hemoglobin 1C. Then we have the last table here to see the association between tumor stage. Very important for us to see also the tumor stage. So tumor stage 1, 2, 3, 4, as we know. And when we look at the hemoglobin 1C, we found that hemoglobin 1C gradually increase, but increase by stage 4. So stage 4 have higher level of hemoglobin 1C. Again, glucose level almost close to each other. So my talk here, I just need to highlight very important point, which is I can go to the second and last actually slide before I give a little bit of biomarker study. We need to tell the people that under diabetes for a long time to do some screening, early screening for any type of lesion. It doesn't matter renal cell carcinoma or lung or liver or other, but this is very important. In addition to control the glucose level, that's very important. But sometimes early stages of this type of cancer, it's very hard to detect. But if detected in early, that's very good to treat, as you know. But of course, we need to tell the people under chronic exposure to diabetes for 5, 10, 7, 5, 7, 10, 15 years, they need to screen for any early lesions. So, but in addition to that, we need to find a biomarker. So if we can find at least biomarker to detect early lesion in this patient, that will be good. So in my lab, I'm almost there. Like 2-3 minutes, I will be done. Because you said one, I just need to tell you or share with you some interesting data from my lab. We do mainly a lot of work in animal, rat and mice. In addition, we need to find out if diabetes, as we see in the rat and mice, that will affecting mainly, since we are interested in kidney, affecting the kidney function and develop some tumor later on. So can we find at least biomarker to detect the early lesion in patient in future? This is what my actual goal. So when we did the study for 8 months, so when we used the beats in rat for 8 months, 1 month, 5 months, and 8 months. When we look at the glucose level, of course, glucose level is very high in all diabetic compared to control. So we didn't actually, that's normal for us. But the important point when we look at when we get the 24 urine collection, and we start to look at proteinuria in those animals, we found that double increase in diabetic compared to control at 1 month, also double increase in 5 months, but almost like maybe 12-fold increase in 8 months. We link that very importantly to one of the markers we use in the lab. It's called DNA damage. So this is the DNA damage. When you look at this blue color compared to glucose proteinuria here, and if I put actual glucose will be matching, you can see increase in diabetic at 1 month, increase in diabetic in 5 months, huge increase by 8 months. So this is what I'm talking about, chronic exposure, chronic living with diabetes. 8 months is that always not 2-3-fold, like sometimes 7 or 8 times fold. And this is a biomarker we measure in the lab, very sensitive method, so it can tell us this will be actually useful as a new biomarker. We can actually detect new lesion, because this biomarker involved in mainly in modifying the cell to cancer cell. I will stop here and I will actually see if you have any question regarding the clinical study and also biomarker.
So right now we don't have any screening tests for RCC, renal cell carcinoma patient with diabetes. So just if we do this one, so patients who have increased proteinuria, we can
Right.
say that they are at high risk for those things? Or should we do the renal cell ultrasound or studies on those patients who have proteinuria?
Sometimes ultrasound and all the, I can say very sensitive, but sometimes in early lesions, very small lesions, when we get the blood from the human and just do some at least analysis like this type of biomarker, compared to normal people, you will see very high. And I'm talking about diabetes compared to cancer also. So normal people here, diabetes here, kidney cancer here. I'm talking about just kidney cancer. So when we find that diabetes, they have higher levels than normal, that gives us indication those people under risk. We need to watch those people. We need to keep going that at least to find if they have early lesions and so on. And this is what my point. Without biomarker, and this usually funding NIH and other funding organizations, they support us, they help us to find biomarker. Early biomarker would be good to at least prevent a lot of complication, because diabetes itself is a complicated disease. So you can, once you add another very chronic disease, cancer, that would be more complicated. So if we can find at least early biomarker at the level of like we can tell that this is higher risk here. Keep in mind, you need to go to the doctor and do blah blah blah. So at least we can stop, or not stop, at least delay or prevent this type of progression, which is very important for us. And this is what our goal in the lab, to do screening. Of course, we can not do anything in human being right now, but at least animal model give us very open area to work, to tell this is at least useful for human in the future.
All right, well, thank you very much.
Thank you.
Thank you very
Thank
much.
you. Thank you.
That was a lot of information in half an hour.
Yes.
I died to
Science.
squeeze it.
Thank you very much.
Okay. Nice to meet you. Thank you so much. Thank you. So we did it in time.
Yes, ma'am. You flew in.
I can't believe, because Mark came in yesterday. I didn't say